Hi, I'm Dianne Barndt with the Victory Center, and I'm the executive director here. And since it's Breast Cancer Awareness Month in October, we wanted to reach out to our partners at Mercy, and we're going to talk a little bit about different types of breast cancer and our role in that and Mercy's role in that. So, Lori, would you like to introduce yourself first?
Hi, yeah, thank you. Good morning. I'm Lori Dine. I am the Service Lines Community Program Manager at Mercy Health, and I'm happy to be back having this chat with the Victory Center again this month.
Awesome. Bailey, would you like to introduce yourself?
Sure. So my name is Bailey. I am the breast oncology nurse navigator. So I kind of help guide patients that are newly diagnosed with breast cancer throughout their cancer journey from start to finish. So I am very excited to be working with the Victory Center because a lot of my patients utilize your resources.
Fantastic. Awesome. Well, Lori, why don't we start with you today, talking a little bit about some stats and warning signs and that sort of thing.
Sure. So statistically, 1 in 8 women will be diagnosed with breast cancer. It's the breast cancer is this number 2 cause of cancer death in women after lung cancer, but death rates from breast cancer have dropped or held steady since 1989. So we think this is great news, and that drop is likely the result of increased awareness, discussion like this surrounding breast cancer, earlier screening, and just better treatment overall, and resources available to women. So according to ACS, about 288,000, I think, women will be diagnosed with invasive breast cancer this year. And 3.8 plus women are breast cancer survivors in the US. So you hear a lot about breast cancer. A lot of people think, why do we hear about, breast cancer all the time? Because the survival rates are increasing and because it's impacted so many women. I think that's why we hear about it. And let's be honest, we're such valuable members of society and contributors in very important roles. So there's a lot of talk and efforts towards breast cancer treatment and whatnot, because I think the impact on society as a whole, if we were, when bad things happen to women, it's bad for everyone. So risk factors for breast cancer, there are things that you can control and there are things that are not in our control. But the things in our control are reduced alcohol consumption, abstaining from smoking. Obesity is a risk factor because fat or adipose can increase your estrogen. Having a first full-term pregnancy later than age 35 or never having a pregnancy, that is an increased risk factor, just again because of estrogen. Working night shifts is an increased risk factor, and I think that's probably due to sleep deprivation. Things not in our control, number 1 risk factor for breast cancer is being a woman. 1% of breast cancers are in men, but being a woman, you're statistically 100% more likely to have breast cancer. Increased age, as we get older, our risk factors increase. Having a family history, having a personal history, so recurrence can be an issue. Inherited genetic mutations, which is something that I'm hoping soon Michelle Hall, our licensed genetic counselor, can speak to. Your menstrual history, as in starting menstruation late or experiencing menopause early, race and ethnicity, and then having dense breast tissue. We have implemented at Mercy Health a high-risk breast program, which you answer questions at your screening mammogram that are typically questions you might be asked anyway, but it's a little bit more of a deep dive into your history and your medical history and your family history to determine if you are at increased risk for breast cancer, in which case you would be given the option to meet with a licensed genetic counselor and or a medical oncologist to discuss preventive or proactive approaches to early detection of cancer, of breast cancer. And So again, about risk, things that we can do to reduce our risk: physical activity across all cancer types. Increasing your physical activity reduces your risk. And then breastfeeding is also something, if you're able to breastfeed, that does reduce your risk as well.
Can we talk about screening guidelines a little bit too? Because I know that those have kind of changed, I believe, over the last however many years.
Yes, they vary a little bit between the organization, but generally speaking, the consensus is if you are age 40 or older and of average risk, so you don't have that personal history of breast cancer or family history, you should begin talking to your doctor about getting your screening mammogram at age 40. Some organizations say you can get a mammogram if you're of average risk every other year. Many suggest doing that annually. Your risk or having it more frequently could change based on variables like, family history, personal history. If you have dense breast tissue, there are different variables, but at about age 40, if you have a family history, and this is pretty much consistent through all cancer types, if you have a family history, a close relative, your screening frequency is going to be different than those of average risk. You're going to get screened earlier, probably up to 10 years earlier even. So that's really a conversation based on the individual that you should have with your primary care provider or your gynecologist, just to determine what screening schedule is right for you. But definitely have that on your radar by age 40.
Awesome. Awesome.
Yeah.
Good
And
info.
let's see, is there anything just like, so there are varying thoughts on the benefits of doing breast self-exam, because sometimes we get a little hyper vigilant and hyper aware of things and maybe cause ourselves increased stress about things that are just normal. But to err on the side of caution, the general recommendation is be so familiar with your breast tissue that you're able to recognize when something's abnormal. Know you're normal so you can recognize abnormal. So definitely report to your provider immediately if you notice like a lump in your breast or a thickening area, including in the underarm. You want to be from your collarbone down to like the bottom of your bra line and like in your armpits. That's the total area that you kind of want to be doing a survey of. If you have any swelling in or around your breast, your collarbone, your armpit, you'll want to report that. Skin thickening or redness, breast warmth or itching, dimpling of the skin, any changes in your like areola or nipples, and any breast pain. And that's pain that's not your typical like hormonal around menstruation or anything like that, but just pain that feels abnormal. Again, you'll know you're normal versus you're abnormal. So, but
Awesome.
those are the recommendations and guidelines.
Excellent. Thank you so much, Lori. Bailey, maybe you could talk a little bit now about just the different types of breast cancer and different treatments for them.
Yes, absolutely. So many women, when they get a breast cancer, they just think it's like one breast cancer and it's the same as their best friend or sister. And unfortunately, that is very different. So there's many different types of breast cancer, and they all include different types of treatment. So a very early stage of breast cancer is called a ductal carcinoma in situ. It's commonly referred to as a DCIS. So like I said, this is a very early stage, a non-invasive breast cancer. And this is typically treated up front with a surgery. Surgeries can be one of two options, a lumpectomy, which is just the partial removal of that breast, or a mastectomy, which removes the entire breast tissue. Depending on which choice the patient picks, then it would determine the rest of their treatment. But if they were to pick a lumpectomy, most of the time the women would be recommended to have radiation following that surgery. After the radiation would be complete, if the patient does have hormone receptor positive cancer, then medication like an endocrine therapy would be typically recommended by their medical oncologist for about 5 years. Side effects of those are typically very familiar or similar to when a woman goes through menopause. So a lot of patients would possibly have some hot flashes, some fatigue, some bone pain, muscle aches, those types of things. Things that are pretty typically tolerated, nothing too extreme.
So, a follow-up question. So, in to find out what type they have? Is that a blood test? Like if it's a hormone receptor, that sort of thing? How do they figure?
Sure. So when a woman has a biopsy, that tissue sample obviously goes to the pathology department, and they are the pathologist is the one that reads that sample. So he looks at that tissue under a microscope and does different types of stains on that. And that gives us the information that we need to know what type of breast cancer it is, if it's hormone receptor positive, and that kind of gives the doctor a much better idea of what treatment options that they would need.
Gotcha. Okay, great.
Yeah. So then there's also invasive types of breast cancer. So more common ones is invasive lobular and invasive ductal carcinoma. These treatments are dependent on how soon we caught this. So depending on how large that tumor is and if it has moved from the breast to the lymph nodes, kind of varies on what treatment options would be recommended. Most typically, if it's a smaller size tumor and there's no lymph node involvement, usually the patient again would start with surgery, again for lumpectomy versus that mastectomy, whatever the patient would choose. And then depending on that final pathology or that final look at the tissue, would determine if they would need a chemotherapy afterwards or if they can just move straight to radiation therapy. So again, with that invasive ductal, if a patient were to decide that they wanted to have a lumpectomy, it would kind of go pair in pair with radiation. So a lumpectomy typically is accompanied with radiation therapy. If they chose to have a mastectomy and it was a good surgery, all the margins were clear, they didn't find anything unexpected, most of the time that is not needed to have radiation after that. Again, if these ladies are hormone receptor positive, then they would also be candidates for the endocrine therapy that I spoke to about the DCIS. Mm-hmm. So that's kind of the nutshell of invasive carcinoma. There are a few different more specific types of breast cancer. One of them is commonly referred to as a triple negative breast cancer, and that is when those hormone receptors are negative and the HER2 enzyme is also negative. So this is typically a more aggressive type of breast cancer, and it's treated with a chemotherapy before surgery. And then a patient would have surgery and then come back and most likely have additional chemotherapy followed by radiation treatment. So that's definitely a more invasive approach to treating that because it is a little bit more aggressive type of aggressive type of cancer.
Okay.
They also can sometimes use Keytruda. It's a immunotherapy in addition to that chemotherapy. So that's another treatment option that a medical oncologist may prescribe to a patient that has a triple negative breast cancer. That's a relatively new type of treatment. I believe it came out in 2021 that was a beneficial for a triple negative breast cancer.
Okay.
There's also a HER2 is another enzyme type of breast cancer that can be treated with a target specific drug called Herceptin or something similar to Herceptin. And that's typically prescribed. It's an infusion that is given through an IV for about a year. That may be in addition to chemotherapy, depending again on the size of that tumor and if there's any lymph node involvement. But Herceptin is commonly used for HER2 positive breast cancers. Patients that present with an inflammatory breast cancer, that unfortunately is a very aggressive breast cancer, and they would require to have all three. So chemotherapy up front. Most of the time it's recommended that they have a mastectomy to remove all of that breast tissue. And then they would have to have radiation therapy to that chest wall and surrounding lymphatics to make sure that they have the best chance of getting all of that all that cancer out of their system.
Goodness.
So that's kind of the types of breast cancers that we see most often in our patients. Patients that do have metastatic breast cancer, meaning that that cancer has moved to another location in their body, not just where it originated. Oftentimes will have chemotherapy and they can have a goal to control that disease. It's not necessarily a curable intent when we give this treatment, but it's very treatable and maintaining with chemotherapy and radiation therapy. A lot of times patients with metastatic disease do not need surgery because it's elsewhere already. Patients that also have metastatic disease are commonly seen with palliative care teams.
Okay.
So palliative care is a really important role for patients that are going through extensive chemotherapy, radiation, surgery. All those things can cause side effects that are not really desirable. So we want them to be able to have the best quality of life while they're getting their treatment. So palliative care is definitely something that we encourage our patients to go to make sure that they have the best control of their symptoms and encourage that teamwork to get both things accomplished.
Awesome.
I think a lot of people have a misperception that palliative care means end of life care.
Correct.
And it doesn't, it means symptom management. So
Right.
that's something to keep in mind. I think a lot of patients also think that they have no choice but to live in misery with pain and symptoms, thinking, oh, this is what cancer is like.
Right.
And yes, cancer is awful, but there is help for your symptoms
Absolutely.
and your pain, and it can be managed. So it is really important that you advocate for yourself and voice those symptoms and the pain and whatnot, so that you can get the support that will help you.
Yes. And
Okay.
sooner than later, you don't have to wait until you're absolutely miserable and not able to do anything that you enjoy to be able to go to palliative care. If you have symptoms, I would highly encourage patients to get in palliative care so they can get those things managed. So you don't have to live with those symptoms for a long period of time.
Absolutely. And then I think what the Victory Center does just complements all of that as well, because some of the things that we do can help with some of the symptom management as well. So stress, anxiety, depression, pain, sleep. A lot of those things get better when patients go through some of our treatments, which are all complementary, meaning they're non-medical, but things like Reiki or energy work, healing touch, massage, reflexology, all of those kinds of things also are offered to breast cancer patients while they're going through treatment and even 6 months after their last treatment. But we also have things for survivors. So whether they're, a 1-year survivor or a 10-year survivor, they can come to any of our support groups. And we do have a lot that's specific for breast cancer patients. We have a breast cancer support group for any type of breast cancer that meets twice a month. And that's the second and fourth Tuesday of every month at 6 o'clock at our Toledo office. And then we just started a metastatic breast cancer group that we do in collaboration with Mercy. And that is co-facilitated by one of the clergy at Mercy, as well as Lori Naus, who's one of the staff members, and she is a metastatic breast cancer thriver as well, works here. And so that is let me make sure I have the right date. That is the first Wednesday of every month from 6 to 7:30. And they do a Zoom option too. So if somebody doesn't quite feel to coming to Toledo and meeting with the group, they can do the Zoom option too. And then I don't want to forget to mention that we have a post-surgical exercise group just for breast cancer patients called the Pink Ribbon Program. And women can sign up for that. And it's like a 6-week program. And then you can come back as an alumni as well. But it's all Pilates based, like stretching. So they work a lot on range of motion and that sort of thing, which is really good.
Wonderful. Yes, also, I would say breast cancer is especially a cancer that deals with kind of body image issues and issues of image restoration. So the wig bank, I think, is a wonderful component of the Victory Center that women take advantage of all who are facing all types of cancer. But also your counseling as well helps women with maybe body image issues or dealing with mastectomy, things like that. And I think you do it twice a year, right, Diane? The intimacy and cancer talk.
Yes, we've done a couple of those each year as well. So that's something.
Yeah, so keep an eye out for those, everyone, because those are great programs. And I've been a witness of those programs and seen women who have, faced some understandable issues after treatment or mastectomy, and such a helpful program. So.
Yeah. And I think the other thing I would like to mention is just that our counseling is also available to family members, because as we know, cancer is a family disease, and, women might have some issues, of course, when they go through treatment and mastectomies and whatnot, but their partner, their family, their kids can also struggle. So we try to help them as well. So we have support groups for kids, we have a caregiver support group, and we also have counseling available to any of the family members too. So hopefully all together that helps the whole family.
Yeah, so many important resources.
Yes. Well, thank you so much, ladies, for being here today and helping educate the public about different types of breast cancer and what all Mercy does, as well as the Victory Center. So thank you so much. It was great to see you guys.
Thank
Thank
you.
you.
You too.
All
Have a good
right.
day.
Take care.